Hi everyone, welcome to the Universe of Cardiology. This is Dr. Jaitly. In this particular vignette, I'll be talking to you about very briefly the fundamental question: what is coronary artery bypass graft, or CABG as it's known as? Well, it's a surgery performed at a hospital requiring general anesthesia whereby a bypass to the coronary obstructions, or obstruction, is performed using vessels from other parts of the body, namely the leg veins near the calves, or within the chest, the internal mammary or internal thoracic artery that are used. So these vessels which we have within our body, they could be mobilized or they could be grafted, as we call them, to connect between the aorta and distal to the obstruction or beyond the obstructions. Now, take for example on the right panel here, I've shown the two coronaries. Right coronary running the course mostly on the right side of your heart and then behind. The left is descending in front of the heart and mostly continues to the apex and supply the entire left side of the heart. And then there's a branch that runs behind, it's called the left circumflex, which again goes and meets with the right coronary in the back as to supply the back of the heart. So having said that, the plaques are fatty material. They, over a period of time, they develop within the arterial walls in the intimal sections where fibrin, lipid, which is fat-rich, and other substances, they will accumulate and they form a plaque. Now, once the plaques form, like I've shown here, these plaques within the arteries, they form. There could be one plaque, two plaques, three or four plaques, depending upon how many plaques one sees, and you can operate, and the surgeon will choose to say the person has had 1, 2, or 3, 4 vessel bypass. So the CABG is basically a detour, if you will, on the highway to the coronaries. It's like you're traveling and suddenly there comes a sign that, look, you're beyond this highway, it's closed for construction or whatever else, bad weather, accidents, etc. So there's an obstruction there. But they give you a detour sign to follow, so this way you can connect back on that highway after a couple of miles. So it's basically establishing a bypass tour, a bypass detour between the obstruction and the distal, which is beyond the flow. So what happens is now you have an aortic connection where the bypass is grafted. Let's say if you are using a saphenous vein graft, so one end is connected to the aorta, so you're getting fresh blood directly now detouring beyond the coronary obstruction, you see. So this way it's restored and fresh oxygen is supplying to the rest of the myocardium here. Likewise, on this side, if you look at this side of the panel, you have an internal thoracic artery, which is originating from the left subclavian or internal mammary artery, if you will. And the internal thoracic artery, as I said, is a graft, and that's mobilized. And so one end is automatically connected to the subclavian, so that's receiving fresh oxygen anyway. It's just that the other end is mobilized, and the two branches here I've shown, they can be planted distal again or beyond the obstruction. So now you have fresh coronary blood flow again flowing and reestablishing the flow to the jeopardized myocardium or myocardial muscle wall. So what is a CABG? CABG is essentially a surgery where a detour is performed beyond the coronary obstructions so that fresh oxygen from aorta, oxygenated blood from the aorta, is reestablished and the circulation is reestablished to the myocardium, which was under jeopardy, where oxygenation was not being possible. Now, so that is the entire principle of the CABG. Now, what is the actual surgery? Well, without dwelling into the actual surgery, but just so the process is that you're admitted to a hospital, a bronchial tube is inserted and the person remains on a ventilator initially till the chest is opened in the operating room after incising the sternum, which is the breastbone, and then the thoracic cage is visualized and it's separated with a clamp to visualize the entire heart. Now, commonly used saphenous vein grafts or internal thoracic artery grafts, as I said, they are mobilized and the coronary obstructions are determined. Now, increasingly, we are we are using more better techniques called the minimally invasive CABG or off-pump procedures, which I will delve on into a separate video vignette. But here, the CABG per se itself takes about 3 to 4 hours because the heart and the patient has to be on a heart-lung machine, as we call it. And if that HL machine continues to pump oxygenated blood, that's the whole purpose, during the surgery while the heart is actually resting or stand still, so that the surgeon can operate very skillfully and put all these grafts distal or beyond the obstructions, originating from the aorta or originating from the left subclavian. So once we have those grafts placed into them, then at that point the patient is weaned off the pump. It's called taking the patient off the pump, and then the heart resumes its beat. So very interestingly, the surgeon prefers to work on a still heart, so this way the skills are not compromised and the surgery is performed very comfortably. Now, one can also perform the surgery these days on off pump. That means the patient is not on any heart-lung machine, and while the heart is beating, they slow it down to the level that the heartbeat is extremely, extremely slow, just enough to suffice for circulation enough. And then at that point, the artery is, that particular artery, while the surgeon is working on, will actually be clamped, and a quick detour or a graft is placed beyond the obstruction, and the circulation is restored. Then the surgeon works on the other grafts and so on and so forth, and again, off-pump surgery is being performed now for several years. Minimally invasive CABG, or where there is actually no cracking or incising of the sternum or the breastbone, which obviously takes somewhat a little longer toll on the recovery. The minimally invasive surgery is performed between the intercostal spaces, between the ribs, in other words. And again, that requires minimal intervention, and obviously a faster healing and a weaning process is the advantage, and a minimal morbidity or mortality, I would say, and a quicker, much faster recovery process post-op. So, lot of advances happening in the CABG world, but just so that you know that it is a procedure routinely now done for several decades, and it has improvised greatly. The heart-lung time or the pump time is obviously, it's a concern for the surgeon as well as for the outcome of the patient. So the longer somebody stays on the heart-lung machine, it takes a little longer for the person to recover, obviously. But so obviously more efficient, more quicker. The surgeon works with all the skills available between the surgeon and the team and the hospital personnel and the equipments. Things could be rather very fast and efficiently performed with highest skills available for the best outcome possible. So in a nutshell, CABG is 2-vessel, 3-vessel, or 4-vessel, normally indicated after the coronary obstructions that have been determined based on a coronary angiogram, earlier done by the interventional cardiologist in a cath lab, and so on and so forth. And the person recovers, sits up the next day after the surgery, the ventilator is weaned off, patient starts to feel better every day as then the person starts to walk, eat, and then is discharged, only to be followed by the surgeon a couple of times and his cardiologist. And later on, the patient goes back into a cardiac rehab to strengthen the muscle as well as regain the strength and the vigor. So it's a wonderful procedure, and if it's recommended, I think somebody should really go for it, because it has been determined by your physician, your cardiologist, that a CABG is recommended. So obviously, initially there is a concern that it's an open heart surgery. It may entail a lot of things, but hopefully I've been able to answer some of your questions. And again, sit down and discuss with your surgeon as well as with your physician the pros and cons, the complication rates, etc., before you decide to go for surgery, obviously. Okay? And hope you and your family feel a lot comfortable after discussing this with amongst yourself. And feel free and look into more data from other texts and journals and websites, if you will, to supplement your information. But for now, take care. Thank you so much.